Okay, good evening and welcome to today's live streaming of Air Clinic's PLAB-1 discussion class. We are currently in cardiovascular system and we're going to continue from where we stopped the last time, which was yesterday, right? And we'll review questions in cardiovascular system, currently in 72%. All right, so the question is about a 75-year-old man who collapsed while walking in his garden. He recovered fully within 30 minutes with blood pressure of 110/80 millimeters of mercury and a regular pulse of 70 beats per minute. Has a systolic murmur. On examination, his activities have been reduced lately, which he attributes to old age. What's the definitive diagnostic investigation that will assist you in his condition? Collapsed while walking, regular pulse, right, Dr. Chara? And this was the answer. That means you've passed here. Passed here. That means we were in 82%. Right? Yeah. Looks like it. Looks like that was the last question. For real. Well, I also think we'll answer this one too. 76-year-old man is in the CCU 2 days after an acute myocardial infarction. He tells you that he had an episode of rapid pounding in the chest lasting for about 2 minutes. He remains conscious throughout. What is most likely reading? 2 days after an myocardial infarction. Tells you that he had an episode of rapid pounding, that's palpitations, which lasted for about 2 minutes. He remains conscious throughout. Most likely reading supraventricular tachycardia, ventricular fibrillation, ventricular tachycardia, ventricular ectopics, atrial fibrillation. Any clues? He had an acute MI 2 days ago. All right. Then now he had an episode of rapid pounding, that's palpitations, lasting for about 2 minutes, during which he remains conscious. So which of these things will happen and the patient will still be conscious? Ventricular ectopic. I think it's ventricular ectopic. Ventricular ectopic. Ectopic occurs once in a while. It's like missed beats. Like it occurs. You can have multiple episodes anyway, but not in like rapid succession. That's what I think about ectopics. Like occurs once in a while. Well, you could be right. He had an acute myocardial infarction. And we know that with myocardial infarction, there will be affectation of the cardiac myocytes and also affectation of the conducting pathways of the heart, from the SA node to the internodal pathway to the AV node to the bundle of His, right, to the right bundle branch, left bundle branch, interfibers, right? And even ventricular fibers as well. So where could the issue be? A bit pounding in the chest lasting for about 2 minutes. He remains conscious throughout. Well, you may be right because of that consciousness. Yeah. So ventricular ectopy. Let's look at let's take see what we can find that we don't already know. Ectopic beat is a disturbance of the cardiac rhythm frequently related to electrical conduction system of the heart, in which beats arise from fibers or group of fibers outside the region in the heart muscle, ordinarily responsible for impulse formation. All right. So normally the pathways I mentioned are where impulses should come out from. However, an ectopic beat arises from outside these channels, right? And begin to have, you can either have a premature ventricular contraction, which is known as a PVC, or premature atrial contraction, which is known as a PAC, all right? So in these cases, some patients describe this experience as a flip or a jolt in the chest or a heart hiccup. That's interesting definitions or expressions. While others report dropped or missed beats. Okay, so ectopic beats are more common during periods of stress, exercise, or debility. They may also be triggered by consumption of some foods like alcohol, strong cheese, or chocolates. It's a form of cardiac arrhythmia in which ectopic foci within either ventricular or atrial myocardium or from finer branches of the electric transduction system cause additional beats of the heart. All right. So, like they explained, patient had a myocardial infarction. So, which means some part of the heart, part of the cardiac myocytes are probably dead. So they are now at risk. So if some are dead, it means some will be ischemic, maybe the ones surrounding the infected cardiac myocytes will be ischemic. So it's either in the atrium or in the ventricles. Those ischemic ones will have a likelihood of releasing ectopic beats, normal beats, all right, to show that they are something is wrong. So ectopic beats may become more frequent during anxiety, panic attack, and the fight or flight response due to the increase in sympathetic nervous system activity or due to parasympathetic failure, stimulating either more frequent or more vigorous contractions and increasing stroke volume. All right. The consumption of nicotine, that's smoking, alcohol, epinephrine, caffeine, even and cheese may increase the incidence of ectopic beats due to their influence on the action of cardiomyocytes. All right. So let's take a look at these PACs, PVCs, and PACs. Right. So PVC is a relatively common event where the heartbeat is initiated by Purkinje fibers in the ventricles rather than by the SA node. That's interesting. Premature ventricular contraction. So um, they may cause no symptoms or may be perceived as a skipped beat or felt as palpitations in the chest, right? Because the reason why we actually chose this answer was because when the patient was having, if a patient was having supraventricular tachycardia, very likely that the patient may feel a little bit dizzy, you know, maybe associated dizziness because of reduction in blood flow. If the patient is having ventricular fibrillation, of course, then will likely pass out. Ventricular tachycardia can lead to ventricular fibrillation, so it's also a very severe stuff. And atrial fibrillation is also very severe. You cannot just be feeling palpitations without while being fully conscious. So what really gave us the idea is the level of consciousness. All right. So how do you identify it on an ECG? This is what it looks like. Like you have P, QRS, P, and all of a sudden you have ventricular beats that is so big, the premature ventricular construction. All right, it's so large, it's premature, so it's coming before the time you're expecting it to come. Right. Let's see. Also known as arrhythmogenic. Okay. The symptom of an underlying heart condition, such as arrhythmogenic right ventricular cardiomyopathy, sounds of an irregular heartbeat. Let's see. Are you by chance hearing that sound? It's irregular, very, very irregular. Can't hear it. Let me see whether I'll increase my volume further. Can you hear it now? All right. So I guess I'm the only one hearing it. No problem. But it just sounds like irregular. All right. So normal you have lobbed up, lobbed up, lobbed up. You know, it's regular. But this one, lobbed up, up, lob, 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 like irregular. Okay. So they may cause chest pain, a faint feeling, and fatigue, or hyperventilation after exercise. So let's see another ECG with PVC. We have QRS. So this wave is not looking very normal, essentially. But in between, you now have something that faces the opposite direction to the normal waves. So it looks abnormal. All of a sudden, you have something. So that's a PVC. It has so many causes, all right? Even lack of sleep, exhaustion, myocardial infarction, myocardial contusion, myocarditis, smoking, stress, alcohol, drugs, including smoking, cigarettes, caffeine, alcohol, nicotine, theobromine, right? Cheese, all of them. Hypercapnia, hypoxia, hypertension. So it has a myriad of causes. Even electrolyte disturbances, hypokalemia, diuretic, hypomagnesemia, all right? Cardiomyopathies, both hypertrophic and dilated, digoxin, antiarrhythmic agents, hypercalcemia. You know that hypercalcemia goes in the opposite direction with hypokalemia. So they both cause similar things. Adrenaline excess. All right, get back to the question. A 78-year-old man suddenly collapsed. His heart rate is 120 beats per minute. Blood pressure is 70/40. This patient is in shock. 70/40. Examination, there's a pulsatile abdominal mass. All right. What's the most appropriate diagnosis? We have options: aortic aneurysm, mesenteric cyst, umbilical hernia. aortic aneurysm as a diagnosis. All right, very correct. There are features of shock with pulse of 120 beats per minute and a blood pressure of 70/40, and sudden collapse of the patient with pulsatile mass in the abdomen. Right, so it's a ruptured aortic aneurysm. Patient is bleeding internally, having an internal bleed. So this patient requires an urgent, emergency surgery by the cardiothoracic surgeons. Emergency cardiothoracic surgery. All right, and or let's say emergency vascular surgery by vascular surgeons. Right? You need to open the abdomen and find out. But meanwhile, it has to do an abdominal pelvic ultrasound scan, which will confirm the findings and should be taken to the theater for vascular repair, aortic vasculoplasty. 79-year-old woman has been diagnosed with type 2 DM. Her BMI is 22. This patient is has normal BMI. Random blood sugar are 8 and 10 millimole per liter. Her blood pressure is 130/80 millimeter of mercury. Her fasting cholesterol is 5.7 millimole per liter. She's currently symptom-free but has microalbuminuria. What's the single most appropriate drug? It's not similar to the one we answered before. Yeah, it is very similar. So AC inhibitors and glibenclamide, AC inhibitor and metformin, statin and AC inhibitor. Remember that the normal total fasting serum lipid is 5. All right. Anything above 5 is abnormal, said to be elevated. All right. While the total cholesterol is 3, should be less than 3. Then no, I said total cholesterol should be less than 5. Then what's the other one? LDL cholesterol should be less than 3. Then triglycerides should be less than 2. Okay. So you probably have to give a statin, right? But because of the presence of microalbuminuria, we have to also give something to protect the kidneys, right? So, and we discussed that in type 2 DM, when a patient is just newly diagnosed, all right, you want to first of all begin with the first stage of management should begin with diet and exercise. So, in the absence of improvement with just diet and exercise, you now move on to stage 2, where you now involve oral anti-hypoglycemic agents, oral anti-diabetic agents, right? So if there's still no improvement, you move on to stage 3, where you now include insulin therapy in a type 2 diabetes. All right, so answer is this. An 80-year-old man with prostatic cancer has confusion, increased taste, abdominal pain, and an abnormal ECG. What's the most appropriate investigation? Prostatic cancer has confusion, increased taste, abdominal pain, and an abnormal ECG. So what's the relationship between all these things and prosthetics here? Okay, probably from bony metastasis, right? MRI of the spine, radionuclide bone scan, dexamethasone scan, serum alpha, alkaline phosphatase concentration, serum calcium concentration. So we're going with serum calcium, right? Most appropriate. Nice. So marked shortening of the QT interval. You know that hypercalcemia can shorten the QT interval. Why hypocalcemia and hypokalemia causes prolonged QTC syndrome. All right, but hypercalcemia is shortened QTC syndrome. The confusion test, abdominal pain. All right. The relationship between prostate cancer and hypercalcemia is when there is bony metastasis, because the most common metastasis of prostate cancer is to the spine, right? The weight-bearing bones, okay, which includes your long bones like the femur, the pelvis, but the commonest place it goes to is the spine, the lumbar vertebrae, right? That's why most patients with prostate CA complain of low back pain, and some of them can, in severe cases, can come down with paraplegia or paraparesis. All right, an urgent serum calcium. A baby born at 34 weeks with a heart murmur is kept in the incubator for almost 4 weeks. There is no murmur at discharge. What's the likely cause of this murmur? A murmur that comes and goes, or a murmur that is present when a child is premature and disappears when a child gets older. No murmur at discharge. Yeah, it is patent ductus arteriosus. What happens to patent ductus arteriosus? Like patent ductus arteriosus is normal in the intrapartum environment, right? Because there's a different circulation for the baby. All right. There's something known as the fetal circulation, which is totally different from the adult or normal circulation outside the the uterus. All right. So as soon as the baby is born, there's going to be a rush of air into the lungs. All right. So as soon as the lungs get inflated and the child starts breathing, there's now increased what happens now? There's now an increased pulmonary pressure. So the right ventricle, pressure in the right ventricle will also increase. All right. So eventually, there's also something about the foramen ovale, all right, that is supposed to be patent as well, but it's closed with all this increase in the right atrial pressure as well. It will be closed. So that connection between the right and the left will no longer be there. All right. Then ductus arteriosus as well connects the atrium and the aorta, the arc of the aorta and the pulmonary arterial trunk, right? And that's important because in the fetal circulation, the child is not breathing on his own. So all the blood that is supposed to go to the lungs would have come from the maternal blood, all right? Oxygen and nutrients would have come from maternal blood and will pass through the veins, all right, into the superior vena cava, inferior vena cava, finally into the right atrium. But from the right atrium to the left, to the right ventricle, even in fact, some of it will even cross through the foramen ovale to the right, to the left side, right? Then it will enter the right ventricle. Some of it will enter the right ventricle and eventually get pumped to the pulmonary artery, all right? But because there's no lung inflation, there's no breathing, the child doesn't breathe when it's intrapartum, the blood will be channeled again through ductus arteriosus into the aorta where it goes to the from where it goes to the circulation. All right. So in a normal child that has been born, there's no need for that anymore. Right? There's no need for that connection anymore. So because of increase in what do you call it, prostaglandins, all right, which should cause vasoconstriction, all right, those ductus arteriosus will close. Okay, but if perchance you give, that's why you don't give NSAIDs to a mother during the third trimester, because you're going to inhibit the prostaglandins that are supposed to assist the ductus arteriosus to close. So eventually, ductus arteriosus will remain patent, which is a problem after birth, right? So it's a cause of non-cyanotic heart murmur. And you know that patent ductus arteriosus will cause a continuous mechanical murmur, all right? A murmur that transverses both the systole and diastole, known as a continuous mechanical murmur. So the key is PDA. As it is more common in premature baby, management is indomethacin, which closes the connection in the majority of cases if associated with another congenital heart defect amenable to surgery. Then prostaglandin E1 is useful to keep the duct open until after surgical repair. A child was brought in to emergency department by his parents for taking his granddad's medication. There's an extra systole in the ECG. Which drug was taken? There's digoxin, losartan, atenolol, ramipril, bendroflumethiazide. His granddad. What's the granddad likely to have? Most elderly people will have something that has to do with the heart. So this child has taken the medication. Yeah, probably heart failure, all right, or maybe hypertension. So, but the presence of an extra systole suggests that that's like ectopic beat on the ECG. So we know that some antiarrhythmic agents also cause trigger arrhythmias in normal individuals. So things like digoxin. A hypertensive patient on bendroflumethiazide 5 milligram per day has come for his routine checkup. On examination, blood pressure is 145/85 millimeter of mercury. Laboratory, potassium is 5.9. This is elevated. Sodium is 137, which is normal. What is the most appropriate management for this patient? So the issue is, on this drug, come for his routine checkup. Bendroflumethiazide is supposed to cause hypokalemia, but here we're having hyperkalemia, and the blood pressure is still not controlled. All right. So what do? You stop the medications? Do you continue with same dose? Do you increase the dose? Do you decrease the dose? Do you repeat the blood test? It's not that confusing. They gave 2.5 milligram per day of bendroflumethiazide. All right. So he now came for his routine visits, and you did a laboratory investigation. First of all, you checked his BP. BP is 145/85. It's not yet controlled. All right. Then you did his laboratory assessment, serum, all right, serum, electrolytes, urea, and creatinine, and you got a potassium of 5.9 millimole per liter, which is elevated, slightly elevated. That's like mild hyperkalemia. Then sodium of 137, which is normal. So what is the most appropriate management for this patient? No, you are the one that is confused. All right. So it means that this dose of bendroflumethiazide is not controlling the blood pressure. That's what it means. All right. It's not controlling the blood pressure. So in that case, you have to increase the dose, and increasing the dose will also take care of business as well, because this potassium is not too high, it's just marginally elevated. All right. So increasing the dose will reduce this potassium down to normal, and as well reduce the blood pressure down to normal. So you will kill two birds with the same stone. Hmm. I think they should repeat the blood test. You will go for repeating the test. All right. The key is E. Repeat the blood test. Endoflumethiazide causes hyponatremia and hypokalemia. So, but the findings are opposite. So it's my fault for believing their tests. All right. So opposite, which is probably error of tests. All right. Hence, blood tests should be repeated to confirm the level of sodium and potassium. Hmm. So when you see a test that doesn't keep in touch with what you expect to see, you repeat the tests. All right. So don't believe everything you see. All right. A man after myocardial infarction presented with sudden breathlessness and dyspnea. On examination, they found scattered pansystolic murmur all over the pericardium. What is the next investigation that will lead to diagnosis? After a myocardial infarction presented with sudden breathlessness and dyspnea. On examination, there's scattered pansystolic murmur all over the pericardium. When you hear a murmur, the next thing you should think of is an echo. When you hear an arrhythmia or palpitations, the next thing you should think of is an ECG. So the key is B, echo. Sudden breathlessness, dyspnea suggests mitral regurgitation and secondary to papillary muscle rupture, right? Following an MI, yeah, mitral regurgitation. But on the other hand, pansystolic murmur all over the pericardium suggests ventricular septal defect. However, in that case, a 2D echo will help you. Man brought into the emergency department after being stabbed in the chest. Yeah, pansystolic murmur can either be a VSD or tricuspid regurgitation. Yeah. A man brought into the emergency department after being stabbed in the chest. Chest is bilaterally clear with muffled heart sound. Was stabbed in the chest. Blood pressure is 60 millimeter of mercury over 0. Diastolic is pulse is 120 beats per minute. JVP is raised. What's most likely diagnosis is clear. It's cardiac tamponade. All right. Once the lungs are clear, you go for the heart. All right. So it's cardiac. And the evidence of raised JVP as well tells you it's cardiac tamponade. A man was brought to the emergency department from a shopping mall after collapsing. All right. He is conscious and answering questions right now, but probably before in the shop, he wasn't conscious. It shows irregular rhythm. Your choice of investigation will be, we just answered this. Man was brought to the ED from a shopping mall after collapsing there. He is conscious and answering questions right now. All right. He has already done an ECG, all right, which shows an irregular rhythm. What do you do next? Do you do a CT scan, MRI, 24-hour ECG, echo? Yeah, we'll go with 2D echo because the ECG shows an abnormality. Assuming you did an ECG and it was normal. No, it's not 24 hours ECG. Assuming you did an ECG and it was normal and the patient has palpitations, all right, you go for a 24 hours ECG. But when you do an ECG and you found something, you go to the next line. Like when a patient comes with any cardiac pathology, there are three investigations you must do: chest X-ray, ECG, 2D echo, right? In that order, like that's how we do it, right? So if by chance there's a need, so like a patient comes with an arrhythmia, in fact, a myocardial infarction, the first thing you should do is an ECG, right? So the situation determines what you do first. The patient comes with a heart murmur, the first thing you should do is a 2D echo, right? That's where things are working very well and everything is being done instant. The minute you just request for it, it's being done immediately. So echo may show clot in atrial appendage responsible for this attack of transient ischemic attack secondary to atrial fibrillation. So then had a TIA following an atrial fibrillation. Remember, it's an irregular reading and he collapsed as a TIA. Okay, transient ischemic attack. And what echo does is to show you are looking for clot in the atrial appendage. In fact, in the left atrial appendage. Okay, and the best kind of echo that will really show you this clot in the left atrial appendage is transesophageal echo. So DOE, transesophageal echo. So usually when you have a patient that has atrial fibrillation and you want to anticoagulate the patient, or let's say you want to do cardiac, what do you call it? Cardioversion, right? You want to do a DC cardioversion, okay? But before you do that, because atrial fibrillation is a risk factor for thrombosis, right? Remember I mentioned that stasis, hypercoagulability, and endothelial damage are the risk factors for thrombosis. So in this case, atrial fibrillation can cause stasis. Okay, so you begin to have formation of clots will lodge in the atrial appendage. So if you do a cardioversion, as you have an acute MI that occurred within 48 hours and is a very severe one because there's the patient is unstable, all right? Maybe the patient is in shock, cardiogenic shock, and all that, okay? And you urgently want to do a cardioversion. However, you don't need to anticoagulate the patient before that cardioversion because it's within 48 hours. But what you must do is that you must do a TOE, that's transesophageal echo. That's the most sensitive. If you do a ecutaneous transthoracic echo, you may not get much, right? It will not be able, because remember that the left atrium is at the back of the heart. So it's that transesophageal echo that will show you the left atrium very well. Right. A man with prosthetic heart valve underwent hemicolectomy and after some days complains of left hypochondrial pain, fever, and has a systolic murmur. What is the next investigation to ascertain the cause of? He has a prosthetic heart valve. He underwent hemicolectomy and after some days complains of left hypochondrial pain. Left hypochondrium is the area of the stomach with fever and has a systolic murmur. All right. What's the next investigation to ascertain the cause of the heart failure? Yeah, you're probably right. Probably right. In new onset systolic murmur, thinking of infective endocarditis, blood culture. Yeah. So post surgery, in fact, before every surgery, when the patient has a prosthetic heart valve, ought to you ought to give prophylaxis, antibiotic prophylaxis. All right. blood culture. The diagnosis is infective endocarditis. Fever plus new onset murmur is endocarditis until proven otherwise. Important risk factors include dermatitis, IV injections, renal failure, organ transplantation, diabetes mellitus, post-operative wounds, risk factors for abdominal valves, aortic or mitral valve disease, tricuspid valve in IV drug users, and prosthetic valve. So anything that has caused a previous injury to the valves, or in a situation where you have a prosthetic valve, then you must be careful about the risk for infective endocarditis because it's increased. So you have to always look out for it before every surgery. Give medications and even dental procedures, you should give medications. A newborn baby is brought with pansystolic murmur at sternal border, but the baby is not cyanosed. All right, pansystolic murmur at the sternal border, but the baby is not cyanosed. What is your diagnosis? So this is congenital acyanotic heart disease. Congenital acyanotic heart disease or acyanotic congenital heart disease. So which of the following can cause a pansystolic murmur at the sternal border? We have tricuspid regurgitation, and I don't want to give you the answer. Mitral regurgitation also causes pansystolic murmur. Are you still there, Dr. Shara? Oh, you are still booting. It's not atrial septal defect. Pansystolic murmur is ventricular septal defect. We know that the congenital acyanotic heart disease include patent ductus arteriosus, ventricular septal defect, atrial septal defect. All right, but pansystolic murmur is classic for VSD, tricuspid regurgitation, and mitral regurgitation. I've mentioned this thing like 100 times. Acyanotic, of course, they are acyanotic. Okay, so VSD is acyanotic. Tetralogy of Fallot is cyanotic, and they told you that this patient was not cyanosed. So that is the pointer, right? So the actual clincher was this pansystolic at sternal border. This one helps you to localize, and they purposely did not put tricuspid regurgitation here because maybe that would have confused you a little because it says pansystolic murmur at sternal border. A patient had a TIA, which he recovered from. You know, TIA is like a stroke which occurs, transient loss of consciousness, which occurs within 24 hours with full recovery within 24 hours. So he has a history of stroke. Past an examination shows heart rate is sinus rhythm. He is already on aspirin 75 milligram and antihypertensive drugs. What other actions should be taken? A TIA, all right, and nothing in the rhythm is normal, right? He's a known stroke patient. He's already on aspirin 75 milligram and antihypertensive drugs. What other actions should be taken? Do you add clopidogrel only? Do you increase the dose of aspirin to 300 milligram? Do you add warfarin, that's anticoagulant? Do you add clopidogrel and statins? Do you add statin only? What do you do? Okay, you will increase the dose of aspirin, Abby. Right. Important clinchers in this question is include TIA and recovered, right? Aspirin 300 milligrams start and 75 milligram daily. Here we even do 300 milligrams start, 150 milligram daily, because TIA and recovered. But the patient has stroke in the past. So history of stroke, clopidogrel is better than aspirin in this regard for secondary prophylaxis. So 300 milligram start and 75 milligram daily. Then sinus rhythm, no atrial fibrillation, hence no need for anticoagulation. That was why they mentioned this sinus rhythm. The Royal College of Physicians guidelines, recommendation for TIA prophylaxis. So patients with non-disabling stroke or TIA should receive treatment for secondary prevention introduced as soon as the diagnosis is confirmed, which includes patients with non-disabling stroke or TIA in atrial fibrillation should be anticoagulated as soon as intracranial bleeding has been excluded with an anticoagulant that has rapid onset. There's so much stuff here that it's now getting confusing. Level 1, when in doubt, go back to the origin. All right. What was the topic we're even thinking about? We are talking about what TIA. Should I be in cardiology? Sef? That should be that should be neurology. Neurology. Uh, we are here for TIA. Lesions. Search button here. Very fun. Yeah. Yes, I found you. So consists of CVS consists of stroke and transient ischemic attack, The cause for both are the same. All right. So brain ischemia results in brain infarction. Brain ischemia results in brain infarction. Stroke is symptoms which persist for more than 24 hours, whereas transient ischemic attack persists for less than 24 hours. So 24 hours is the cutoff between stroke and TIA. Types, the Oxford stroke classification puts the two types. Um, the following criteria should be assessed: unilateral hemiparesis and hemiplegia. But I don't want to get into the types for now. There's obviously total anterior circulation infarct. There's partial anterior circulation infarct. Shara, I know you left, but I had to continue because I'm on a video. I'm on live stream, so but that's not the topic. There's posterior circulation and all that. Other recognized patterns, lateral medullary syndrome, medial medullary syndrome, Weber syndrome, all those stuff, right? But what we are looking for is the management. So transient ischemic attack. NICE issued updated guidelines relating to stroke and TIAs in 2008. They advocated the use of ABCD2 prognosis score for risk stratifying patients who have had a suspected TIA. All right. Criteria. Criteria includes ABCD2. All right. That means age more than 60 years has a score of 1. That's more than or equal to 60 years has a score of 1. Blood pressure more than or equal to 140 over 90 millimeters of mercury has a score of 1. Clinical has a score. That makes it ABCD 2 prognosis score for risk stratifying the patients who has suspected TIA. So anything above 5, above 6, greater than or equal to 6 is high risk. Okay. So a total scoring of 7 in the ABCD2. Second D is diabetes. Sorry, you say you're not seeing the screen. Aspirin. So management. So people who have had a suspected TIA who are at a higher risk of stroke, that is with an ABCD score of 4 or above, should have aspirin 300 milligram daily started immediately. That's a TIA patient who hasn't had stroke before in the past. You start them on aspirin 300 milligram start immediately, all right? Then specialist assessment and investigation within 24 hours onset of symptoms. That means you're supposed to do either a brain CT scan. For ischemic CVS, a brain CT scan may not be able to pick the ischemic CVA within 48 hours, right? So a brain MRI is better within 48 hours, all right, for ischemic, for infarcts, right? Ischemia. But if it were to be hemorrhagic, anytime you do a CT scan to pick it up. So measures for secondary prevention introduced as soon as the diagnosis is confirmed, including discussion of individual risk factors. So if the ABCD score is below 3, specialist assessment within 1 week of symptoms, including decision on brain imaging, that CT scan. If vascular territory or pathology is uncertain, refer to for brain imaging. People with crescendo TIAs, that's 2 or more episodes in a week, should be treated as being high risk, even though they may be having an ABCD score of less than 3. So antithrombotic therapy, you use clopidogrel, is recommended as the first line for patients who have had a stroke. So once anybody has had a stroke or in the past and then has a TIA, clopidogrel is the first line, right? So aspirin plus dipyridamole should be given to patients who cannot tolerate clopidogrel, right? So if clopidogrel is the first line, but if a patient cannot tolerate clopidogrel, you can now give aspirin, you add dipyridamole to it. As a patient that has had stroke in the past and has a TIA currently. So with regards to carotid artery endarterectomy, let me see what I can do about this screen not showing up. I'm afraid for my live stream. Let me see. All right, so you see my challenge has entered level 2 now. Okay. I'm glad that the live streaming continued. So I'm gonna share. I'm sharing my screen already. I believe you can see my screen now. I believe so. All right. So we are still on antithrombotic therapy. With regards to carotid artery and endarterectomy, recommend if patient has suffered a stroke or TIA in the carotid territory and are not severely disabled, it will only be considered if carotid stenosis is more than 70%. So remember yesterday, I think we came across a question that talks about carotid artery stenosis. So one of the things that you do when a patient has an infarct, apart from CT scan or MRI, in on the situation, when a patient has a TIA or a stroke, you also want to do that's an infarct. You've done a brain CT, you've done an MRI, and it suggests an infarct, that's an ischemic stroke. You must do a carotid artery angiography. All right. You can do a CT angiography, you can do an MR angiography, all right, which will help to determine the degree of stenosis. First of all, if there is a stenosis in the carotid artery and the degree of stenosis in the carotid artery, all right, the degree of stenosis, if it's above 70%, it's said to be significant. And in that case, you have to do something called a carotid artery endarterectomy. Then, in addition, other things that you do include an ECG to help to rule out atrial fibrillation and other arrhythmias. Then 2D echo as well will help to rule out cardiac murmurs and other heart diseases. All right. Then causes of CVS, we have thrombosis, emboli, thromboembolism, hemorrhage. All right. So all these three, thrombosis, emboli, and thromboembolism, all fall under the category of ischemic CVA. So ischemic CVA can be caused by a thrombus, embolus, or thromboembolus. Okay. Then hemorrhagic CVA. So patients are elderly with sudden onset of symptoms. You think ischemic more than hemorrhagic. Hemorrhagic tends to occur more in younger patients. All right. And hemorrhagic is more severe. Like patients with hemorrhagic CVA is likely to be unconscious. Is more likely to be unconscious than a patient with ischemic CVA. Patient with ischemic, you can see the patient just maybe with mild facial deviation, mild hemiparesis. All right. But patients with ischemic CVA, most times they are unconscious, especially when it is massive. All right. And they are usually younger patients. All right. And their blood pressure also is markedly elevated following a hemorrhagic CVA more than an ischemic CVA. So hemorrhagic or untreated hypertension. Carotid atherosclerosis or carotid artery disease is the cause we have, and the symptoms that you have will give you a suggestion on where the stroke is occurring. Okay, so I just want us to look at some investigations. Like I mentioned, atrial fibrillation, you do an echo, all right? And also intracardial, you are looking for intracardial emboli, especially in the left atrial appendage region, and a transesophageal echo would be the best. All right. If recent MI, echocardiogram to see mural thrombi. Then if carotid blue, it means atherosclerosis. Then Doppler ultrasound scan of the neck also suffice. Then if history of ischemic heart disease, it means atherosclerosis is present. Then Doppler ultrasound scan of carotid artery and vertebrobasilar artery needs to be done. If patient is diabetic, then blood glucose. Okay, blood pressure measurement to rule out hypertension. Heart murmur, it means that a valvular heart disease which can cause emboli. You do an echocardiogram to see the emboli. Thoracic aortic aneurysm, chest pain radiates to the back, interscapular aneurysm, different blood pressure in both arms and different pulses. That's radial synchrony, radiofemoral delay. Investigation to make your diagnosis, CT scan of the head, all right, both ischemic and hemorrhagic, but you do not do CT scan within 48 hours when you're suspecting ischemic CVA because you may have a false negative, all right? So MRI will be better within 48 hours. So general management of cerebrovascular accident. If the patient has symptoms of stroke, do brain CT scan to exclude hemorrhagic stroke. No hemorrhagic stroke, then you give clopidogrel, right? 300 milligrams start, followed by 75 milligram daily. If patient presents within 3 hours and no hemorrhagic stroke, arrange thrombolysis. Yeah, if patient presents within 3 hours, that's when you think of thrombolysis. And those patients down here don't present much later. So if you get a patient that actually presents within 3 hours and you have done your brain CT scan and it's confirmed that there's brain MRI, it's confirmed that you have an ischemic CVA, you actually do a thrombolysis, right? That's where alteplase, tenecteplase, antifibrinolytic agents, right? Alteplase, tenecteplase, streptokinase will come in place, right? If patient has symptoms of stroke which have now resolved, it means he had a TIA that's resolved within 24 hours. You give aspirin 300 milligram orally even before doing a brain CT scan because symptoms have resolved, which suggests TIA. So treatment with statin should be given to all patients with ischemic stroke or TIA unless indicated. You know why you have to confirm the diagnosis? You have to confirm what type of stroke. Because if, for example, a patient is having hemorrhagic CVA and you think the patient is having ischemic CVA and you give aspirin, that patient will bleed more. Bleeding will worsen. All right. And also, there are some ischemic CVAs that can also transform. There's something called hemorrhagic transformation. So can transform again to become hemorrhagic. So you have to be careful when you're managing CVAs to give the right medication. Patient, I'm managing a patient for ischemic, and let's say you do a thrombolysis, and the patient is hemorrhagic without confirmation, the patient will now bleed further, which is likely going to lead to death. Right. So there's also a place for use of statins. Treatment with statins should be given to all patients with ischemic CVA or TIA unless contraindicated. So for prophylaxis, after stroke, 2 weeks later, you start aspirin 300 milligram followed by clopidogrel 75. After TIA, aspirin 300 milligram day 1 followed by 75 milligram aspirin daily. So you come back home. So with all these theories, what we're actually looking for is that a patient had TIA, which he recovered from, right? He has a history of stroke, an examination shows heart rate, sinus reading. So he doesn't have atrial fibrillation. He's already on aspirin and antihypertensive drugs. Other action should be taken. It's not you don't it's not by increasing the dose of aspirin to 300 milligrams, because aspirin is not the drug of choice um, for a patient that has heart stroke. So in that case, you add clopidogrel and statin. So a patient is on loop diuretics. What effect do loop diuretics produce? Low sodium, low potassium, low sodium, normal potassium, high sodium, normal potassium, high, low. So where do we go? This one is simple now. Answer this one before. Yeah, low. What's the effect of loop diuretics on calcium level, as opposed to diazyl diuretics? Yes, it causes hypocalcemia. That's pan. All right. A patient on hypertensive drug develops hyperkalemia. Which antihypertensive is likely to cause it? Ramipril, atenolol, thiazide, nifedipine, furosemide. So it's simple too. When you see straightforward, be one thing among these options. Ramipril, atenolol, thiazide, nifedipine, furosemide. I'm going to answer it for you. Is ramipril. ACE inhibitors cause hyperkalemia, as well as ARBs. Thiazide will cause hypokalemia. Furosemide will cause hypokalemia. Atenolol has no effect on potassium. Nifedipine has no effect on potassium. Patient presents with irregular pulse of 162 beats per minute. What drug is most useful initially? Amiodarone, digoxin, bisoprolol, warfarin, heparin. They didn't give us the age of the patient. So we don't know. First of all, the diagnosis. What's the diagnosis? Diagnosis is atrial fibrillation, right? So which drug will you use initially? As when you don't know the age of the patient. I think it's amiodarone. Remember, in atrial fibrillation, there's concept of rhythm control and rate control. But in a situation where we were not giving the age of the patient or any other factor that will help us to determine what type of control we'll go for first line. Initially, I think the clincher here is most useful initially. So you've changed your mind from amiodarone to beta blocker. All right. So thank God you changed your mind. So beta blocker most likely in acute atrial fibrillation, and first line is bisoprolol or verapamil, and second line is digoxin or amiodarone. Okay. When in an acute setting, Remember that in acute setting, you will choose rhythm control, while in chronic settings, chronic atrial fibrillation, you will choose rate control. So among the beta blocker is contraindicated, you go for verapamil. Like in a situation where a patient is asthmatic or diabetic, you cannot use beta blockers. All right. For a patient that has bradycardia, but this patient has bradycardia anyway. So if there was contraindication to beta blockers, you would have gone for verapamil. Okay. The patient came to the hospital with a complaint of severe chest pain lasting for more than an hour. Following ECG tests, the patient revealed to have ST depression. For the first time since we started solving this question, the person has seen ST depression. All right. So he was already on aspirin. What is the most specific treatment for this patient? Let's make a diagnosis. He came to the hospital with complaint of severe chest pain lasting more than an hour, right? And it shows ST depression. He was already on aspirin. Was the most specific treatment for this patient. The glycerin, nitrate, simvastatin, beta blocker, clopidogrel, low molecular weight heparin. He chose glycerin trinitrate. What was the diagnosis? I think it's glycerin trinitrate, right? But there's an explanation given there about the most feared complication of atrial fibrillation is likelihood of throwing an embolus. All right, because there will be some stasis, and that embolus will now go and lodge in the brain. That's when the patient now has a transient ischemic attack or a stroke. All right, following an MI or following atrial fibrillation. So, want to give something. Okay. A patient, 50-year-old smoker and heavy drinker, presents with complaints of racing heart. The 24-hour ECG comes out normal. What's the next step in management? Smoker, heavy drinker, he has palpitation. 24-hour ECG comes out normal. They went a step further and told you that 24-hour ECG comes out. What's the next step in management? Do 2D echo, you reassure, do stress test. Have we answered this type of question before? I think we have. That the smoking, and drinking are enough to cause to cause palpitations. So there may be no structural heart. You can do it. You can do an echo and it's normal. Do an ECG and it's normal. 4 hours ECG for that matter is also normal. So you want to reassure him. Okay. This reassuring they are saying, eh, I think I would prefer to say cancel this patient. Don't just reassure. Reassurance just sounds like, Madam, you are doing well. Just go home and rest. There's no issues in your heart. But there needs proper counseling. By now, with this, these are harbingers of bad omen coming in a few years' time. But this patient gets to 60, he's already having palpitations now. Fine, he's not hypertensive, he's not diabetic, but he's a heavy drinker and a chain smoker. Before he gets to 60, 70, he'll come down with something. So these palpitations, just a part of the heart playing. So yeah, you're probably right. Counseling is part of reassurance. All right. A white Englishman with a past history of myocardial infarction is a known hypertensive and diabetic. He's currently on aspirin, statins, and metformin. What would you add to the treatment? Past history of MI, known hypertensive, diabetic, currently on aspirin, statins, and metformin. What would you add? Beta blocker, AC inhibitor, insulin, diuretic, calcium channel blocker. Yes, this one is just testing your knowledge of diabetics, like management of hypertension in diabetics. AC inhibitors or ARBs are the first choice for management of hypertension in diabetics, right? Because they have dual function. Apart from reducing the blood pressure, they're also renal protective. And we know that there's something called diabetic nephropathy. It shows up as, first of all, microalbuminuria and gradual decline in renal function. All right, so AC inhibitor, a woman had an oxygen mask and glycerin 40 beats per minute. Bad elevation, inlets 1, 2, and 3 as an inferior MI. So what's the next step? She had an MI, she got less some oxygen mask, and chest pain has improved, so that's not the issue. Then her heart rate is 40, she's bradycardic. There's increased likelihood of stasis. It shows ST elevation, still in keeping with the MI. So this one implies an inferior MI, right? Like 2 and 3 as an inferior MI. So what's your next step? Do molecular weight heparin, kinase, angiography, continue current management. None. Dr. Shara, what do you do? When you have no idea, you just keep quiet. To be as if you did not even see the question. Okay. Yeah. Why is it streptokinase? Streptokinase is what? Antifibrinolytic. No, it's a fibrinolytic agent. That's streptokinase. Are we doing fibrinolysis? Find out indications for fibrinolysis in myocardial infarction. Indications: fibrinolytic therapy is used in the treatment of ST segment elevation, that's STEMI, acute stroke, and other less common indications such as pulmonary embolism and acute DVT. Fibrinolytic therapy must be instituted within 24 hours of symptom onset. I think it was any duration. Since the introduction of pharmacologic reperfusion therapy in the 70s, the main goal of reperfusion treatment has been to restore early, full, and sustained patency of the infarct-related artery. Right? Fibrinolytic therapy was the primary reperfusion strategy that was available in management of patients with acute ST elevation, MI. An initial analysis consisted of 9 clinical trials. All right. Demonstrated that there was a significant reduction in the mortality associated with the administration of fibrinolytic therapy compared to control subjects not receive. All right. So mechanism of benefits, we already know the mechanism of action. So thrombolytic fibrinolytic therapy is indicated for the treatment of STMI if the drug can be administered within 12 hours of the onset of symptoms. The patient is eligible based on exclusion criteria, and primary percutaneous coronary intervention is not immediately available. So it means the first choice for an MI that you caught early should be percutaneous coronary intervention. So if you are still within 12 hours and PCI is not available, readily available, and go ahead and do fibrinolysis. That's fibrinolysis, thrombolysis. After 12 hours, the risk associated with thrombolytic therapy outweighs any benefits. So you must do it within 12 hours. After 12 hours, don't bother because you are increasing the risk more than the benefit. Because irreversible injury occurs within 2 to 4 hours of the infarction. There's limited window of time available for a perfusion to work. Thrombolytic drugs are contraindicated for the treatment of unstable angina and non-STMI. That's interesting. We know that acute coronary syndrome consists of unstable angina, STMI, and non-STMI. So you only use thrombolytic therapy for myocardial infarction patients. That's ST elevation myocardial infarction patient. That's STMI. Okay, we don't use it for unstable angina and non-STMI. For the treatment of individuals with evidence of cardiogenic shock. So you don't use it in cardiogenic shock. Although no perfect thrombolytic agents exist, an ideal thrombolytic drug will lead to rapid reperfusion, have a high sustained patency rate, speak for recent thrombi, be easily and rapidly administered, create a low risk for intracerebral and systemic bleeding, have no antigenicity, adverse hemodynamic effects, or clinically significant drug interactions, and be cost effective. Currently, the available thrombolytic agents include streptokinase, urokinase, alteplase, recombinant tissue plasminogen activator. Right, that's where alteplase, tenecteplase, etc. belong. Recombinant tissue plasminogen activator. But streptokinase and urokinase are cheaper than these ones. So more recently, thrombolytic agents similar in structure to recombinant tissue plasminogen activator, such as betaplase and tenecteplase, have been used. All right, apart from alteplase. These newer agents boast efficacy at least as good as the other ones, with significantly easier administration. Thrombolytic agent used in a particular individual is based on institution preference and the age of the patient. So depending on the thrombolytic agent being used, anticoagulation with heparin or low molecular weight heparin may be used, may be of benefit. All right. Side effects: intracranial bleeding, and CVS, right? Possible side effects of thrombolysis, and even systemic bleeding. The degree of effectiveness of a thrombolytic agent is depending on the time since the myocardial infarction began, with the results occurring if the thrombolysis is used within 2 hours onset of symptoms. If the individual presents more than 12 hours after symptoms commence, give the thrombolysis, that's the best time to even give within 2 hours. But if you still find the patient within 12 hours, you can still give, but it will not be as effective as within 2 hours. Then beyond 12 hours, the risk of intracranial bleeding, CVAs, outweighs the benefits that you will get from, because by then the infarction has already occurred and it now becomes irreversible. All right. In cases of failure of thrombolytic agent to open the infarct-related coronary artery, the patient is then either treated conservatively with anticoagulants and allowed to complete the infarction, or PCI, that's percutaneous coronary intervention, which is normally the first choice, is performed. Percutaneous coronary intervention in this setting is known as rescue PCI or salvage PCI. That's when you do it after you've done thrombolysis and after a failed thrombolysis. Now becomes salvage PCI or rescue PCI. Complications, particularly bleeding, are significantly higher with rescue PCI than with primary PCI. So I think revised guidelines for the management of patients with ST elevation MI. Class 1, in the absence of contraindications, fibrinolytic therapy should be administered to patients with symptom onset within the prior 12 hours and ST elevation greater than 0.1 millivolts, at least 2 contiguous leads. Right. In the absence of contraindications, fibrinolytic therapy should be administered to STMI patients with symptom onset within the prior 12 hours and new or presumably low left bundle branch block. Okay, on this one's now senior stuff. I think we've gotten what we want. So they are correct. That's the, you catch an MI All right. Next thing to do is a PCI. That's apart from you have to give an urgent 300 milligram of aspirin. You give glycerin trinitrate to reduce the pain. You give morphine to reduce the pain. You give intranasal oxygen if SpO2 is less than 95%, right? And possibly you may have, if patient is hypertensive, you may give a beta blocker, all right? Then now the definitive now is when you now hurry. Of course, you must have done your investigations, ECG, 2D echo, etc., etc. Okay, then you must now hurry to do. If you catch the patient within 2 hours, you hurry. In the if PCI is available, you do a PCI. That's your first choice. Natively, percutaneous coronary intervention, because it's both diagnostic and therapeutic. Because during that procedure, you'll be able to do an angiography and also see the vessels that are affected. Then you go ahead to remove the directly, and some even go as far as injecting antithrombolysis, that's thrombolysis, into the clot through that percutaneous coronary intervention. All right, so that's the first choice. But in a situation where it is not available, you now go for your antithrombolytic, thrombolytic therapy, right? That's fibrinolytic therapy with streptokinase, urokinase, or recombinant tissue plasminogen activators, tenecteplase, retaplase, right? So the protocol. A woman presents with history of falls, becomes pale and clumsy. She is hypertensive and takes atenolol, bendroflumethiazide, and amlodipine. What investigation is needed? Hypertensive that falls, becomes pale, and clumsy. She's already on antihypertensive medication. Which investigation would you do? 24-hour ECG, 24-hour BP monitoring, ECG, echo, CT of the head. What are you thinking about? You chose brain CT scan. Like what's going on in your head? Like which diagnosis are you thinking about? That made you choose brain CT scan. You must have a reason now for everything that you do. Even if you're not correct, but at least have a reason, which your reason may be correct. Because splinter is what I highlighted. So the patient has frequent falls. What about the pale? What about the pallor? Okay, you are thinking of TIA or what? Hypertension alone. There's something else going on. And there's something else that they're pointing you to, because they mentioned all the antihypertensive the patient is on. Patient is on atenolol, bendroflumethiazide, and amlodipine, like 3 antihypertensive medications at once. So don't you think this patient is having a postural dizziness or falls? You may be correct anyway, but you're mentioning tumor. Where is tumor coming from now? Tumor is far-fetched. I even thought maybe you're thinking of a TIA or CV or something. Igbo language, we say Nekworoka, as you have finished work. All right, so falls, becomes pale. This may be hypotension, like considering the myriad of drugs that this patient is taking, atenolol, bendroflumethiazide, amlodipine. So maybe let's do a 24-hour BP ambulatory monitoring. I may be wrong, but that's what I'm thinking from the facts that are presented. So that's correct. So you understood, like, whenever you see things like this, you have to ask yourself, why did they list all these drugs? They told you, normally they could have asked this question without even, they'll just tell you she's on antihypertensive, what's the investigation? But they listed all the drugs that the woman is on. That's to tell you she's on um, multiple therapies. Okay, she's on beta blocker, she's on thiazide diuretic, she's on calcium channel blocker. So it means maybe the dose have increased, right? Probably the patient, you need to reduce the dose or maybe even remove some of one of the drugs. All right. Probably hypotensive. That pallor is what gave it away. After an MI, a man presents with pansystolic murmur, which is radiating to the axilla. What is pansystolic murmur that radiates to the axilla? What is the disease? Tricuspid regurgitation, mitral regurgitation, aortic stenosis, mitral stenosis. Have you seen the new question now? It should be from your own end. But you can still answer this question without even seeing it. After an MI, a man presents with pansystolic murmur, which is radiating to the axilla. This is classical for something. Without seeing the options, you give me the answers. But let me still give you the options. Tricuspid regurgitation, mitral regurgitation, aortic stenosis, mitral stenosis. I know that you are murmurs. You people don't cross the same path. No. Radiating to the axilla is mitral regurgitation until proven otherwise. Is mitral regurgitation, right? When they tell you a murmur that is radiating to the pansystolic murmur that is radiating to the axilla, you know that the mitral valve, I told you now, the mitral area is on the fifth left intercostal space, mid-clavicular, and that's the location of the apex. So just imagine it is easy to radiate to the axilla, just like the aortic valve is on the second intercostal space on the left, on the right. So it's easy to radiate to the carotid region. That's how it goes. It radiates to the contiguous areas. So murmur of mitral regurgitation is pansystolic. I've been saying it, I've been hammering on it. I said there are three murmurs that are pansystolic: tricuspid regurgitation, ventricular septal defects, and then mitral regurgitation. So mitral regurgitation is different from the other two because the other two are in one location. It's in the front intercostal space, parasternal, left lower parasternal border. But mitral regurgitation is in the apex. So from there, it radiates to the axilla. That's classic. Are you seeing the questions now? Or like it's stuck in the previous one? Yeah, I think maybe you should be the one to leave and come back. Let's. So for those who are watching live, the next question is about an 18-year-old man who complains of fatigue and dyspnea. He has left parasternal heave and systolic trail with a harsh pansystolic murmur at the left parasternal edge. What is the most probable diagnosis? 18-year-old is a young man, complains of fatigue and dyspnea. He has a left parasternal heave and systolic trail with a harsh pansystolic murmur at the left parasternal edge. Sarah is back, so we get the answer. Is it working now? Are you seeing it? Are you seeing the current question? You're not seeing the screen at all. Okay. Let me do my own maneuver now. So I'm back. Let's see how it goes. I believe you will see it now. You are seeing it now, right? I know you are. Okay. An 18-year-old man complains of fatigue and dyspnea. He has left parasternal heave, systolic trail with a harsh pansystolic murmur at the left parasternal edge. What is most probable diagnosis? Options include tetralogy of Fallot, ASD, VSD, patent ductus arteriosus, transposition of great arteries. What do you think? Keep in mind that he's 18 years old and there was no mention of cyanosis anywhere in this question. Yes, you are improving. You're becoming friends with murmurs now, gradually. Gradually. So it's a VSD. The VSD. I think at this point we should end it after this one and just leave 9% tomorrow. Tomorrow, self, we should be able to finish this one and enter nervous system, right? So we should finish it. The streaming will be too long. Okay, I know what I'll do. Right? I'll end the stream and enter a new one. Okay. So an 82-year-old male suddenly becomes unconscious and fell down. He recovered completely within minutes. What's the best investigation for you to die? Fell down. For you to die. Unconsciousness and fall. He recovered within minutes. What's the best investigation for you to diagnose this? ECG, EEG, blood glucose level, brain CT scan, chest X-ray. Someone that has hypoglycemia will not recover now until you do something. EEG is about seizures, right? ECG, if there's didn't give us any history of anything that suggests that he has a cardiac disease. And they didn't tell us that the patient was decking or, maybe he had generalized tonic-clonus or anything. Just fell down, fell unconscious. Within minutes, he woke up. So probably had a TIA, possibly. All right. We are wrong. Is ECG sudden unconsciousness without any provocation, which makes arrhythmia the most likely cause. Hence, we should do an ECG. Anyway, we are going to CT scan, but we are still in cardiology. An 82-year-old man suddenly becomes unconscious. So without any provocation, you should think of an arrhythmia first. Question was, just cut it off. All right. An ECG of an elderly lady who collapsed in the emergency department shows rapid ventricular rate of 220 beats per minute, QRS of 140 milliseconds. Normal QRS complex is 90 to 120. All right. So this one is widened QRS complex. What's the probable diagnosis? Atrial fibrillation, ventricular tachycardia, Mobis type 1 and 2, sinus tachycardia, supraventricular tachycardia. What is your answer? This is the type of question that you use and be shining in the exam. It's just straightforward. I just told you that the QRS is widened. In atrial fibrillation, nothing is wrong with the QRS complex. It's just that there's absence P waves, right? And there's irregular reading, which they did not mention whether wave is irregular or irregular. The only thing is that ventricular rate, that's heart rate, 220 beats per very high, right? And QRS is widened. It's not supraventricular. Supraventricular tachycardia is narrow complex tachycardia. That's to say that the QRS complex is normal, right? But in ventricular tachycardia is wide complex tachycardia. So QRS, supraventricular means it's above the ventricles, which means it's either from the AV node or from the atrium. All right, that's where the tachycardia is coming from, and that means that QRS tells you about ventricular contraction, whereas P waves tell you about atrial contraction. Yes, atrial depolarization or atrial contraction or atrial systole. That's what P waves tell you. Then QRS complexes tell you about ventricular contraction or ventricular systole, ventricular depolarization, right? So if there's anything that affects the ventricles, like in the case of ventricular tachycardia, then you expect that to be a widened QRS complex. Okay. Then if there's anything that affects the atrium, all right, in the case of supraventricular tachycardia, you expect that to be absent P waves or P waves hidden within the QRS complex. what happens in supraventricular, the P wave will be absent. Or let's say now in atrial fibrillation, P wave is also absent. All right, rhythm is irregular. So this is ventricular tachycardia. Ventricular tachycardia, one, there's history of MI, ischemic heart disease. What are you talking about? History, if ischemic heart disease or MI, likelihood of a ventricular arrhythmia is more than 95%. 12 lead ECG, and 3, lack of response to IV adenosine. ECG findings in favor of ventricular tachycardia. So ventricular tachycardia doesn't respond to IV adenosine, right? Unlike supraventricular tachycardia that responds to IV adenosine. So that also tells you, even before you do an ECG, let's say you want to urgently try IV adenosine and see whether it will work. So you're just getting rapid ventricular rhythm. SVT can also give you that high rates. Remember tachycardia, that word tachycardia. I told you that tachycardia can either be sinus, supraventricular, or ventricular. So when it's sinus, there's P waves, but there's tachycardia, heart rate above 100. All right. Then when it is supraventricular, there's absence of P waves, but there's tachycardia, heart rate above 100. Usually even above 150. Then when there's ventricular tachycardia, the QRS is widened, right? So, but there's tachycardia, and it's coming from the ventricles. And ventricular tachycardia, if left untreated, can become ventricular fibrillation. And ventricular fibrillation, if left untreated, within 2 to 3 minutes, will lead to death. All right, so you see the pathways. So ECG findings in favor of ventricular tachycardia: positive concordance in the chest leads, positive QRS concordance, marked left axis deviation, atrioventricular dissociation occurs in 25%, or 2-in-1 or 3-in-1 AV block, fusion beats or capture beats. In the given case, collapse ventricular rate of 220, both QRS complex, 140 milliseconds, points towards ventricular tachycardia. So all these ones now, extra stuff. Just know that the widened QRS complex and this other extra stuff was ventricular tachycardia, because in supraventricular tachycardia, you don't have all these ones. Let's look at it. Differences between SVT and VT on ECG. This is an MCQ question. If they can even put it in tabular form, I prefer it. So these are the features favoring ventricular tachycardia on ECG. Extreme axis deviation favors, like when you look at an ECG, like what they're trying to say is that when you look at an ECG, it may be difficult for you to completely say that this is ventricular tachycardia or that this is supraventricular tachycardia. Like if you have a supraventricular tachycardia that in which there is an associated left bundle branch block, do you know that can happen? You have an SVT. SVT is supposed to have narrow complex tachycardia, right? But when there is an additional bundle branch block, it will now cause widening, because bundle branch block causes widening of the QRS. So when you have supraventricular tachycardia plus bundle branch block, you will now have widened QRS complex. So at that point, you are now confused. Is this a ventricular tachycardia or is this a supraventricular tachycardia? So that's the point where you may now want to try IV adenosine. And IV adenosine will not work if it's a ventricular tachycardia, but it will work if it's a supraventricular tachycardia, right? And you also look out for some other features on ECG. If you have an extreme, you look at the axis. you have an extreme axis deviation, likely to be a VT. All right. You have a broad complex more than 140, even though BBB with SVT may be broad, but if it's more than 140 milliseconds, it's likely going to be a VT. And in our question, it was actually that 140 that they used, right? Yeah, they used 140. So they actually used the cutoff, specific cutoff. So AV dissociation, that's atrioventricular dissociation. That's the atrium is beating on its own, ventricle is beating on its own. That's AV dissociation. All right. Then fusion beats is another one called capture beats. So all these things are things that point you towards more than fusion beats, capture beats, and AV dissociation, extreme axis deviation, and QRS complex more than 140 milliseconds, and trial of IV adenosine. All right. So let me end this live stream here so that I can put up another one.